We're not going to get into the weeds as far as actual coding and what the rules are by insurance payers or state by state, because we don't have enough time for that. So before we get into it, I want to introduce myself. I'm Logan McKnight. I have been in the neuromonitoring space for almost 18 years. I've got 12 years of experience talking, learning about billing. I started asking about billing when I was the director of business development, because I found out our company I was with at the time started billing patients. I wanted to understand that better, so I started meeting with our billers weekly, and honestly, it was transformative to my relationships with the surgeons. So fast forward, I moved to Seattle and I became the VP and then CEO of a neuromonitoring service company, which also had professional oversight, and then a medical billing company. So I've been doing this for a while, but the thing I am not is a certified coder or biller. So I want to clarify that. And just so you guys know, what I do now is I do my own coaching and consulting firm. I'm very focused, if you guys have seen any of my posts on LinkedIn, which you probably have, on leadership development and improving systems, not just for neuromonitoring companies, but for also med tech. I'm launching my first group coaching program for managers who are in the field starting September 23rd. I'm really excited about that. I don't think that's been something that's been offered in our field for at least as long as I've been exposed to it. The other things I do is I provide one-on-one coaching, group coaching, consulting for companies, and corporate workshops. So I love doing these things for free. I'm going to try to do monthly webinars. I'm going to send you guys a survey out afterwards. I would love some feedback. I also want to know what you'd like to see in upcoming webinars. That's how I got to this one. So feedback, because as much as I like doing this, I'm doing it for you guys. So, all right, quick history of neuromonitoring billing. Two components. Neuromonitoring has always had the tech component and the professional component. The tech component is what typically service companies bill for. They charge the hospital for, and then the hospital can then go and bill for. That covers, or should cover, the technologist's time, and then typically the equipment rental and the supplies. The professional component is for the, for the neurologist to bill out on, and that's where things get a little bit dicey. So in 2013, they started the G code. And if you guys have heard the G code, that was Medicare, Medicaid, basically stopped concurrent monitoring. So it was kind of the wild, wild west before then, but physicians could no longer monitor simultaneous cases and then bill for them, at least for government cases. And it really started cracking down on the regulations for neuromonitoring. So major changes were really that G code rule, and obviously it breaks it down into 15-minute intervals. Now in 2010, really, I think there's a lot of history with neuromonitoring billing, but they started cracking down. And what I noticed, at least where I'm based in Seattle, Washington, was really major crackdowns started happening in 2015. 2018 was, it felt like they came in waves, but I'm going to get into a little bit more like what those restrictions looked like from a commercial billing. But those are the two components. The first is the tech. That's what you guys are leaving your PO form or your billing form for, and probably marking the CPT codes as you guys are seeing in the TC, which is the tech component. And then you probably put in your EMR system and bill out the PC, or the professional component. Also, a rule that changed was that surgeons and anesthesia, this was way back in the day. I don't know if you could say they ever could bill, but they didn't really specify they couldn't. So there was a time, especially like with the early iteration of the M5, that they were allowing surgeons to bill for this while they were in surgery, and they've cracked down on that since. So here's just some examples I pulled out of random commercial insurance companies that have just picked or chosen different rules for their state, different regulations. So Anthem says IOM is not medically necessary for routine spinal surgeries without risk factors or modalities. It also lists a lot of modalities that it won't cover intraoperatively. Blue Cross of North Carolina requires basically a Society for Neurosurgery guidelines. It flags outside standards as not medically necessary. So they use a lot of research basically to say this, all these procedures are not medically necessary. And what this boils down to basically is the surgeons might still use neuromonitoring, but they will likely get denied when they code to bill the professional component. So it is payer specific. It's also sometimes plan specific. So it states and then it's coverage by payer. And even Anthem or Blue Cross Blue Shield has a lot of different types of I guess, categories within their payers. And then it's also plan specific after that. So there's just so much nuance here. If you guys know a biller, hug a biller, because they are dealing with a lot. But pretty consistently, you can say high risk procedures are covered. Low risk or routine procedures are now, we're seeing a lot more denials. So what that used to look like for out of network. Now for government cases, it was a little different. It's a little easier, but I'm going to focus on what out of network billing. And that's typically what most providers in our space are billing for neuromonitoring. So they would submit a claim and the plan either pays or denies. And honestly, typically they don't pay immediately, especially for out of network. There's a little back and forth tug. So if they deny, the appeal process starts. This is very general, the timeline I'm giving to. Every carrier has a different timeline. That's why I say hug a biller. So you get for most insurances, you get at least 180 days from the denial to file an appeal. And that means you have to produce a lot more documentation, maybe recode it depending on the denial, and then they can give you back the issue within 60 days. And then typically if it gets denied again, you have another 30. So if you really think about it, this process, now we're almost at 6 to 9 months after the date of surgery. So that's a really long, AR time for outstanding revenue. It's a little painful, especially for small companies. If you guys are part of small companies or even maybe a company one, it's really, really hard to rely on payments like that. So now we have a new process, and this is IDR, which is independent dispute resolution or arbitration, if you guys have heard about it. So what it looks like now is you submit a claim, the plan pays or denies. If it's protected, that's a little complicated, but for the most part, they're not protected quite yet. They might crack down on that. It may change, but what happens is you have 30 days to pursue negotiation. If you can't negotiate within the payers, that's when you go to arbitration within 4 business days. So the timeline's really, really tight, but typically what you do is you get a third party in between the insurance and the service provider to agree on a fair cost. And normally it's somewhere between what they were billed and then what was paid out. The issue with that is sometimes companies can, and they do, raise their fee schedule, meaning what they're going to charge for certain CPT codes. So it can get very expensive very fast. And trust me, I am not pro insurance, but I'm just saying it's a fine line. And I think that's where you start to see, a lot of Medicare and Medicaid cases that are reimbursing, $150, and then, commercial payers that were sometimes paying very literally, we were seeing checks for $5. It was a bit insulting. But then all of a sudden you're starting to see checks for $10,000 or more than that. And the disparity is pretty extreme. So what the process looks like, just to kind of put it on paper, is it's 30 days from the initial denial. Then you only have 4 days to take it to an independent dispute resolution. And then you basically work it out within the next 30 days and then a payment, for 30 days. You can batch things together, because if you think about this would be for a large company who a phenomenally burdensome process if you have all these claims that you have to figure out. So you can batch them together if it's similar service plans, similar cases, but still it's a lot of work. And that's why you see a lot more billing companies and arbitration, organizations that provide arbitration coming out now, because the manpower to get it done, or the manpower, is a lot more than it was, certainly 5 years ago even. So a little bit too, because I always got the question, are patients going to get a bill? At the end of the day, the No Surprise Billing Act has changed things. Sometimes what would happen is the patients would see an EOB. An EOB is an explanation of benefits. They're going to see that regardless. The insurance company sends that to you just to break down what they were billed, what they were willing to pay or not pay, and then what the patient might be responsible for. So you can imagine if the patient got a $30,000 neuromonitoring bill and the insurance company paid, $5 of it, and then they said, you're going to be responsible for $29,995. They're going to call their surgeon pretty upset. So that happened a lot. And at the end of the day, every company is going to handle this differently. And so I'm going to tread very lightly when I talk about this. I can't say that this is the rule or this, because it's going to come down to the way they decide to manage their patients. But what a problem is when balance billing, if you guys have heard of balance billing, is when they would take that bill for $29,995 and actually send it to the patient, and then send the patient to collections if they didn't pay. That got a lot of bad press for a long time. And so the No Surprise Billing Act is to protect patients from that. The challenging thing with the No Surprise Billing Act, though, is when you have your fee schedule, they actually told us that we did still have to send patients bills. We always have to send copay and deductible. That's part of the plan, even if you're out of network. But there is some gray area as far as what you have to bill patients afterwards. Some providers were saying, or some payers, I should say, were saying, if you don't bill the patient for the rest of the amount, then you will get fined, or we'll take back all the money we've paid you. So there's a lot of nuance here. And what I would say is, do your best to not talk dollars with patients. When you're talking to them, I know sometimes if you assess them before surgery, they might be, a little agitated and be like, wait, I didn't know we were going to have you. Am I going to get a bill for this? I would say, if you guys have materials that you can leave them, hopefully there's a patient advocate in the billing space, but I would caution you not to say, no, you won't get a bill from us, because it is likely they will still get a copay and deductible. And they may have a patient responsibility depending on their plan. So it's really kind of impossible for us to say. So I also want to break down a big difference between Medicare and commercial plans. Medicare, you can bill the tech component. You probably will not get reimbursed for it. Most of the time, they will only reimburse for the professional component, and only for one instance. So if a neurologist is monitoring multiple cases, they have to be very careful that none of those 15-minute increments are for covering concurrent patients. So that way, typically they'll stagger that. So scheduling physicians can be really challenging for neuromonitoring, trying to figure out the best way to get reimbursed, especially because most hospitals' payer mixes are about 50% government pay. That's honestly a pretty good hospital. Some of them are 60 or 70. So commercial plans, So government plans have a set fee schedule. You bill the government plan. It's posted on CMS's website. You bill that out. You basically get what you get. You get what you get, and you don't throw a fit, as my mom used to say. That's kind of what you get with government cases. And typically reimbursements were between like $150 and $500, depending on the case. So not really enough to sustain business. So that's why there's such a reliance on commercial plans. Many still recognize the 95941, which is the professional code, and you can build that out for multiple patients, even if you're monitoring them at the same time. Now, some providers have gotten wise to that, and they actually are not accepting that code, and they are wanting the G code. So now it's kind of coming back to bite us even in the commercial space. So nearly all payers agree, and this is a very gray area, but that baseline is not monitoring time. That's kind of a interesting conversation, but I think the more important thing is the setup time. You really, as soon as you set baselines, that's when monitoring starts. And then when it stops is when you're done. And that's all you can bill for. The problem is there's just so much variance in commercial plans, the rules, the timelines for billing, and then there's just an incredible variation of what they're willing to pay out. So trying to forecast financially or plan is really, really challenging. So what you guys can do, all of that aside, is produce really, really good documentation. Texts do not code. I know that, you know, sometimes you guys mark down the CPT codes, but at the end of the day, you're not coding the case, you're documenting. You're documenting what you do. So documenting the times precisely and making sure you're recording alerts, especially trying to do it every 15 minutes. And the thing that I used to tell my team all the time was try to get as much of the necessary documents as you can, anything that's relevant to that patient for that case. H&P, obviously, but if you have any pre-op reports or clinic reports or imaging, all of that might have a diagnosis that could help get reimbursed. And the other thing is, you know, even with those exceptions I mentioned earlier for those health plans, if hypothetically they won't do recurrent laryngeal monitoring ever for an ACDF and they don't think it's medically necessary, but you document that this patient's an opera singer. Now the billers have a leg to stand on as far as advocating for the unique case to get this paid. So any information you can provide from talking to the patient, from the chart, is really relevant to help the billers get this across. And like I said, they have a hell of a job to do. So the more we can produce, the better. And for the most part, once you guys leave the room, after that, getting any medical records are really, really challenging. So it's, you know, I know it's a huge pain, especially with the workflow and if you're rushing into a case to have to get all these records, but that's why you guys are probably getting bugged by your companies about it. So documentation directly impacts what can be billed and whether cases or claims will be paid. So try to be precise and thorough and as consistent as you possibly can. And your company probably has rules. And so I think it's also worthwhile to talk about that within your company. I know some people sent me some specific questions, which I'll get into during the Q&A, but I cannot answer specifically how to code because your company might do something different. So something that isn't variable, although people might not treat it the same way, are the compliance basics. So these are the three, what I consider the three, aside from billing compliance, these are kind of the relationships that reps, techs have with surgeons and industry has with surgeons. So there's the anti-kickback statute, which basically says you cannot receive anything of value or referrals tied back to the surgeon. So there are some safe harbor things, but the whole thing of the anti-kickback is basically you cannot refer like services to like if you own a neuromonitoring company, you cannot use that neuromonitoring company. If you own a distributorship that has metal, you cannot use that metal. If you guys have ever heard the term POD or physician-owned distributorships, that used to be a big thing before they cracked it down and created the anti-kickback statute. So Stark Law also bans physicians for self-referrals, and that gets a little complicated, but basically you cannot refer yourself or something that will cause you to get financial gain. That's why they'll ask a lot of times, like, are you part of this practice? Are you, but even then there's areas of gray. you know, if you have a different type of physician in your practice, you can refer within your own practice. Yes, it's not a financial incentive for you, but maybe your practice does better, or maybe that, you know, then that physician is incentivized to give you more referrals. That's not necessarily a violation of the Stark law. So there's, you know, people are wary about this, but there's still so much gray in this space. And I've had this happen a lot where I've, you know, went to go get a cup of coffee for a surgeon when I was doing neuromonitoring, and they've been like, oh, wait, I don't want you to do that. Like the Sunshine Act, which basically said you could only spend a limited amount. You had to disclose how much money you were spending on each surgeon that was utilizing your service or device. That's more for manufacturing companies. And basically, it's just a crackdown on a lot that was happening, I would say, pre-2010, where like companies were taking surgeons on ski trips and things like that and not disclosing them. So those are the major 3 compliance rules. So I know we covered a lot, and I'm going to spend some time in the Q&A to answer as many questions as I can. But the biggest takeaway is it's not illegal to bill the patient for their copay or deductible. So patient billing is going to occur, most likely regardless of, you know, what the rules are. That's just kind of the way it goes. Hopefully it's mainly just their copay or deductible, but it might also be part of the bill that wasn't covered by insurance. Make sure you get your documentation right. I think that's the biggest thing for techs to rely on, is like themselves, their documentation, and what they can provide. The biggest thing I would say too is like the rules change all the time. The only thing I can tell you that I consistently know about billing is that everything changes all the time. So it's very hard to give these type of educational webinars because there's so much moving, and that's why I'm really trying to keep it as high level as possible. And so I hope I didn't confuse it too much, but I do really think I appreciate everyone who's here, because you guys educating yourself and then spreading the word to others is huge to, you know, change the future of the industry to make this more sustainable. If it's going to be sustainable, you guys are going to be the ones who figure out a way to do it. So also, you don't code, you just enable the correct coding, and just remember that. So let's get into some Q&A. This over here. All right, is everybody awake? I did have people ask some questions that I did want to cover a little bit. I'm not going to say who asked them. I'm just going to go through them real quick. If the hospital is to bill the 𝗀𝐶, what modifier do they use? And would they be allowed to use the 95941 or the G code? So those are the professional codes. You cannot bill for them. They would have to use the 𝗀𝐶 modifier, and it's 95940. That's the only coding basic I'll get into. The other tricky thing is audiologists. So a lot of payers won't pay for audiologists, but sometimes you can have physicians overseeing the audiologist, and they would bill under their MPI number. The other thing is there's different rules in different states. I believe California is a state that gives a lot, like audiologists can bill. And then sometimes if they're in the room, they can bill for the professional component. So there's unfortunately a lot of gray that I can't give you a specific there. The other question I got was about ENT cases and whether, like, how many nerves you can bill for. And I actually did a little research because I was just curious, and nobody's gonna like what came up. But what came up is that one, the cranial nerve EMG code covers just any cranial nerve EMG you do, be it one nerve, be it a bunch of nerves, either unilateral or bilateral, and that's it. And then it doesn't reimburse at all for surface electrode recurrent laryngeal monitoring. So it only does needle. Here's the thing. I know our company did it. I know so many companies do it, because otherwise, what are you billing for? You have to bill the time code with a modality code. So a lot of times they probably are billing for that. That's why I say there's no hard and fast rule that I can give you guys, but I do think there are overarching, you know, things to understand. But when you start getting into like the nuance of coding, I suggest you talk to whoever your billing company is, and, you know, whoever is in charge of like your revenue cycle management. Those are the people that are going to really be able to get in the weeds with you guys on why they code the way they do, why they interpreted the CPT code or the rules of the payer that way. So those are all for the questions that came in beforehand. Does anyone have any questions or feel like they need clarification?
I had a few actually, and oh wow, my microphone switched over. You can still hear me, correct?
I can hear you, yeah.
That was weird. I guess what I wanted to know was like, how can like the wording of medical necessity, like who or what really determines like the medical necessity? Because I mean, at least from the neuromonitoring standpoint, like we could all find a bunch of reasons for a case to be reimbursed for what insurance companies would call like routine neuromonitoring. And sure enough, even as recently as yesterday, I had changes on a case that would have been deemed routine.
Right.
And so I guess what I was wondering is like, can surgeons influence that at all? Can they write like a letter of medical necessity? Can any of that be changed or altered on some level to kind of allow for that to be billed for?
So
reimbursed?
Yeah, isn't the surgeon ordering the neuromonitoring? Isn't that deeming it medical necessity?
You would think it would be really nice if that was the way, but what if that's their policy? At least as it stands right now, one surgeon requesting it doesn't override the carrier's policy. What can happen though is when they appeal, the surgeon can write a letter on behalf, or the neurologist or audiologist, whoever was there interpreting the case, can override it. But typically, I mean, you know, especially from the neurologist standpoint, like it's very hard to get the surgeon. I mean, first of all, the surgeon's going to have to write a letter for us to get, you know, neuromonitoring money. I don't know if, you know, there's a chance in hell that's going to happen. But the neurologists who did it, they still probably saw like 10 cases or more that day. So you keeping, that's why I say like the documentation is so important to be like, hey, like let's advocate for this patient getting this. Like, did the patient have like, you know, are they a pro soccer player and they had foot drop? And, you know, this is, yes, I get it. It's a low lumbar case that typically won't reimburse, but this is a unique, it's a, you know, 32-year-old patient. Like, how do we advocate a step farther and get them to see out of the code? I don't guarantee, like there's no guarantees, but it at least gives, I think, the billers the ammo to appeal. Yeah, Matt, I really truly wish it was just that it was like the surgeon wants it and they should be the boss, but gosh, that's a whole other conversation. Like a whole other soapbox about the things that practitioners are just not able to do or decide these days. I know I saw a question come in.
Oh, here we go. Yeah. I understand if the operating surgeon and the facility are both in network, then the patient is not responsible for any costs for IOM at an out-of-network rate as per the No Surprises Act. Does that also mean that the insurance company is not responsible for out-of-network charges and IOM billing is paid out in-network rate from the insurance company?
I may have to think about this one. So at least, and someone please correct me if I'm wrong. To my understanding, IOM is still out of network. And even if the physician's in network and the other providers are in network, you can still bill out of network. You just have to give a reasonable scope. So it's somewhere potentially, if they have a good relationship with the clinic or the hospital, they may have given a good faith estimate is what it's called. And so if they've given the good faith estimate, even though it's out of network and the patient signed it, they can bill and they will bill the good faith estimate typically. Yes, Brian.
So to piggyback off of the out of network, what I'm running into with my company here in Florida is, for instance, Blue Cross. They will kick back any kind of claim that was submitted, asking for like the NPI number or other information that was not included, because they're looking to find my company as like a registered in-network company. Obviously, we provide that information to them, and then they say, all right, we can't find this provider in network. Try again. So they're not even recognizing me as an out-of-network provider at this point. So I have unpaid claims for the whole year because they just won't like recognize the out-of-network part of it.
Are you guys utilizing IDR at all, or arbitration?
So we can't even go to arbitration. My understanding is we can't even go to IDR arbitration because they're not paying anything.
Because they haven't done the initial claim.
Right.
You know, I mean, unfortunately, it does vary a little bit state to state, but I was under the impression that, I mean, that you can still go forward and bill. You know, you can enroll, you may have to enroll, and Christina is, by the way, Christina is on, and she is the director of operations at a billing company. So if she wants to chime in, she's more than free to, but you can register as an out-of-network provider. Are you having trouble doing that in Florida? Is that what you're saying?
So I think that was the most recent step we took, but that's been over like a month and a half ago. We submitted paperwork to enroll, and we just haven't, nothing's progressed since then, and they just kick back every claim that we submit.
Oh, of course. I mean, it's their prerogative to not pay you, right? So I mean, I think the really challenging thing here is that you have to be your best advocate. You have to go after it, and you have to, you know, continually do that. I mean, that's why I say, like, go hug your billers, because they, you know, if you guys have ever had to do business development and you've had to wait in a doctor's waiting room, or, you know, had somebody not call you back or hang up on you, that is a biller's life. That's you know, they are dealing with long hold times and not getting through, dropped calls, and no one responding. And what they do is they, you know, I'd say save all of that documentation. And, you know, in this new space, you may be able to advocate yourself legally, get an advocate for yourself and say, here's all the steps we took. You guys are making it, like, you guys are making it impossible for us to survive or get paid. And, you know, document that, because you may have to do that. And unfortunately, that's what arbitration is they had to get a legal intermediary involved, right?
All right, I'll look into enrolling as the out-of-network provider. Try and follow up with them, but right now we're just kind of at a standstill with them, and I think even United is running it the same way.
United's terrible.
Yeah.
Yeah, I mean, document. I mean, just from your standpoint too, like, collect all the cases that haven't gotten paid. Collect everything you can possibly have, as far as, like, this is when you submitted your claims, this is when you appealed, this is when you reached out, this is when you tried to go out of network, all those things. Just as much as you can, save it, because that documentation is going to help you.
Right. Okay. Thank you.
Mm-hmm. Yeah, and does anyone have any? Oh, go ahead. It's this loud. No, unfortunately, Nisha, there's no more PhD, DB&M. And actually, the challenging thing too is a lot of hospitals, not necessarily in payers, but hospitals only recognize board certified neurologists. And then government payers typically only board certified neurologists. Now, there's some that don't necessarily need to be board certified, but you still need to be a neurologist. And, you know, like, that's a whole other conversation of, like, you know, specifically like PhDs and DAB&Ms, like, with their experience, they probably in some cases are just as good as, you know, physicians, or maybe better, but rules is rules. So unfortunately, them's the rules right now. But, you know, I think like another thing is, a no is not a no forever. Like, that's at least, I mean, that's like my mentality in life. It's like, if you guys continue to advocate and educate, then a no is not a no forever. You just have to create, you just have to create the path forward and figure it out. And I do think it's, you know, making it make sense and making it reasonable that companies aren't also relying on, you know, $10,000, $15,000 checks to keep their doors open.
Are there maybe, and this is kind of open to anyone really, but is there anyone doing that? Like who do we have that is advocating for these for neuromonitoring period? I mean, do we just, I don't know, do we just need someone to go to law school and become a lobbyist? I don't really, you know, I'm not really sure what the path is towards, you know, kind of having an impact on that kind of advocacy.
I don't know of anybody. I know that when they came out with the G code, they did go to Wall Street. There was or not Wall Street, kind of Wall Street. They went to the government. They got a lobbyist, but the problem is that there was never a consensus on how many cases are appropriate for a neurologist to monitor at the same time. And so I guess the way I looked at it is, if we couldn't get our shit together as an industry to be able to agree on something as best practices, how is the government supposed to make a decision? So they're going to make a decision that's just like, okay, well, one doctor, one patient, right? Because they don't know. They don't really understand it. So I think, I mean, to be honest, I used to say stuff like that all the time. And that's kind of why I'm like, well, hell, I'm just going to do this. I'm going to have these conversations with people across, like, you know, across the space, because I do think ASNM, ASSET, all the societies, I think it would be wonderful to have challenging conversations about this type of stuff, of like the sustainability, because I think it's on everybody's mind. Like, how do you make this a sustainable industry if everybody's going to keep their cards to their chest like this? We're not going to talk about the hard-hitting issues. You've got to bring the veil down a little bit and have the conversations. It's an industry built on patient care. I think most of us, if not all of us, got into this because we thought we could really make an impact and we can change somebody's life. And every day we could potentially be saving someone's life. At least that's, you know, what I think is, this is an industry full of really good people, but we have to advocate for our industry, for ourselves, and educate. So I think it's just having these conversations and talking to people across companies, across industries. And so one of the other things I will say is, if you guys don't know each other in this chat, which I'm assuming many of you don't, drop your LinkedIn profile and connect with each other. Please do. I know I've stalked many of you on LinkedIn and found you, and maybe that's why you're here today, but connect with each other. I just can't say enough. I don't think that there's enough connection in our industry and outside of our industry. I think some of my relationships with like my spine surgeons and my spine metal reps, it just gave me like a whole different perspective of the industry, that I realized, you know, we did need to make some changes. And if we could, you know, I know God forbid, but combine, you know, like do automated systems to not burden our techs and neurologists by covering cases that are never going to get reimbursed by insurance, at least right now, and then focus on where are we going to grow the industry and advocate for ourselves in the future so we can get paid. So Brian isn't having to go fight with Blue Cross Blue Shield just to make money. And Blue Cross Blue Shield is like, I think, it's the largest private payer in Florida, right?
Yeah, pretty sure that's accurate.
Yeah, I mean, it's a waste of time and energy, you know, and I really think that you got, like, you know, you guys having these conversations and this continuing, that's why I'm like I said, I'm happy to do it. I want to have conversations about things that you guys want to learn about. And even if I don't learn about it, what I'll do is I'll invite somebody else I know who knows better than me, and they can come talk to you guys. But I think stuff like this will be really helpful. And I think it's great. I think sometimes it gets a little spicy because honestly, like I said, there's a lot of gray in billing, and there's a lot of, you know, what's legal and ethical can sometimes be two different things. But I don't know, I'd rather have the tough conversation than not, right? Thanks for sharing, you guys. Do you guys have any other questions or anything I can help with?
I could fire one more.
Yeah.
Maybe two since we have time. I don't see any other messages in chat right now. You kind of touched on this briefly, but do you have any tips or scripts for kind of dealing with that surgeon who comes to you saying, oh, hey, somebody you work with all the time, for example, like, hey, my patient got a bill for, whatever, $5 worth of bill. Like, what the hell, Do you have any tips or scripts for dealing with something like that?
Yeah, I mean,
from like a technician side.
Yeah, I mean, so if they're coming in hot to you, I just say, hey, I don't know anything about this. Can I look into this and get back to you? Or ask them for their cell phone number. Can I text you back? Can I look into this after this case? Like, you don't want to be doing this diving in a patient care space. And then talk to whoever your billing company is, whether it's inpatient, whether it's within your company or outside your company, and get the facts on that patient. Because there's been many times that I've reached out to our billing company and gotten the facts before I talk to the surgeon, and that totally changed the conversation. Because they are like swearing up and down that it's a bill. Our patient got a bill. I'm like, are you sure it wasn't an EOB? I know the difference. And you're like, all right. And then you go get your facts straight and you realize it is an EOB. And oftentimes what I would also do would be nudge my billing team to go reach out to the patient. Be like, there's an upset patient. This should have, ideally should never get to the surgeon. So let's reach out to them. Let's make sure they're okay. And if, it is a bill like that, I think, it's good to know your company's policies. Like, are they billing? I mean, I think that was what I wanted to know is our company billing patients tens of thousands of dollars for neuromonitoring? Because that's going to make all this feel good stuff that I'm doing of covering, pediatric cases and getting up at 3 a.m. to go do a cranie. Like, it kind of wipes away all of that positivity when you find out afterwards the patient is straddled with debt. And so, like, really, I say, like, ask the hard questions, educate yourself. Christina says, as a billing group, we found a lot of value in meeting with surgeons, schedulers frequently to answer questions. I love that. That was a big thing we did preventatively, was we would go to our surgeons' clinics and drop off billing information and then connect the billing group with the surgeon. And the other thing, and poor Christina had to deal with this a lot through COVID, but was getting the information beforehand. And we even tried a lot with like pre-authing, all the things that didn't work, but we ended up like just opening the conversation to the clinics, created, a partnership between us versus like, we were on opposite sides of the aisle. I know that's not a good answer, but my answer would always be, if they get you in that space, is, hey, like, let me look into. I mean, it's just like, if anything, if you don't know the answer, you don't make something up. That would be like my recommendation for anything. Just, hey, I can tell you're upset. I don't know the information. Let me look into it. Let me do that. Can I text you? What's the best way to get in contact with you? And then it's like you're moving it along. You know what I mean? And then, if you're able to answer that surgeon's question, you become much more than a tech to that surgeon too.
Yeah, that's definitely what my approach was. I experienced that quite a few times, and I know of people who surgeons have approached them, and they were just drawing a blank, and they didn't really have quite the presence of mind to say, like, hey, take a second, I'll take a beat, let me get with whoever I need to get with. And they kind of come to me like, oh Lord, what's going on? He's mad, help. And yeah, that's what I found works. Yeah. It's just, I'll get back to you, let me find out, let me ask my people.
Yeah, the answer isn't, like I said, I mean, if any, I hope that this webinar did not confuse more than it helped. Because I do know there's a lot of gray, and that's why I say educating yourself, finding out the answers, and digging a little bit, because everything is different. And to be honest, even if you do get an answer, I think take it with a grain of salt, because I do think there's also room for interpretation here. And so keep an open mind, recognize if you move states, if you're talking about a different payer plan, like the rules could be very, very different, and just, I wish people, because it's so big and complicated, I think it scares people away, but that's exactly why we need to shine light on it, right? Because it shouldn't be this complicated. It shouldn't be how you go to the hospital and get care and then get that care paid for should not be this labyrinth of, excuse my French, but bullshit. And right now that's what it is. So the only way to pull back the darkness is to shine light on it, and to have conversations like this that ask tough questions. And trust me, there are no tough questions, even if you're like, well, wait, I thought we could bill for the technical code for insurance. Yeah, you can. There are ways that you used to be able to do that, and some companies still do bill the technical code through their insurance, and they do recoup money. There used to be something where you can bundle the technical and the professional code. There's ways too that you can bill under a different company's, you could have a technical company and then your professional company, and they can be two different companies, two different MPI numbers. I know that was something on Reddit, right? It was the way it could be, good, bad, or ugly. And it certainly doesn't look good to have hundreds and hundreds of companies, under your belt that looks a little whatever, but it wasn't illegal. So, but I think I love that the conversations are happening. I like that there's 20 plus people here talking about billing at 7 p.m. So I appreciate it. Does anybody have any other questions, or a tough conversation, or just even an anecdote of something that's happened in your career that you're like, this was a wild story that I feel like people should know more about?
I had a situation with my last company, and Logan, I know I've talked to you a little bit about this, that I was curious about how my boss was billing. And when I found out that information, I was reprimanded because she didn't want me to know how much she was charging the hospital per case versus how much she was paying me per case. And I found out she wasn't billing the patient's insurance at all. She was just charging an astronomical tech fee to the hospital, and somehow getting away with not having professional oversight on any case ever. And then the hospital then was turning around and billing the patient and trying to recoup some of that cost that they were paying out up front. So
yeah, there's
a little shady.
There's a lot of stuff. And I will say too, I mean, the things that will probably not be disclosed to you guys, even if you ask, are going to be hospital pricing. They're just not going to tell you hospital pricing. That's not something they want to advertise. And then the other thing is their fee schedule. One, it's actually illegal to share your fee schedule. You're supposed to keep it like a Medicare and then basically a commercial and out-of-network rate, and that's it. But there's, some companies don't do that. It gets really messy. But the fee schedule is what you say you're going to charge for each CPT code. And typically arbitration or IDR pays that's their benchmark for the companies, because they're billing out their fee schedule. They're billing out whatever their commercial fee schedule. And sometimes it can be $100,000 for a case. They're not planning on getting that, but that's still what they're billing out. And then what the benchmark is for independent, an independent person to come in and try to decide, okay, is it $100,000 or is it $150? What's fair? And in my humble opinion, I think even companies making it if they were able to sustain something like $3,000 a case, you know, across the board. And I know different markets are different, but like, that would be amazing. Honestly, I think the industry would be in a different place. I think a lot of companies' margins would be healthier. I think it would be a more sustainable way of doing things. But unfortunately, what ends up happening when you go and network with them is they're like $400, $350, you know, something that's not sustainable for our field. And so for right now, it's the IDR arbitration just seems like the what's going to happen until insurances get wise, which they do, and put the kibosh on it or figure out a way around it. I would just love to figure out a way to band together as an industry to say, like, this is really what we're looking for. This is really what's acceptable. This is what's going to keep even the little players going, right? Like, this is what's a sustainable model. And so, like, let's aim for that. Let's aim for a little bit more for the complex cases. Let's aim for a reasonable average if we're monitoring something else, and then, you know, don't be greedy. But that, I think you guys educating yourselves is step one. So I really do appreciate you taking the time to be here. Any other questions? Okay, well, I'll send this out afterwards. If you guys don't mind completing the survey, I appreciate it, because also I would love to know how I'm doing, if you guys were looking for anything else from this webinar that you didn't get, and then what you could get from future webinars by reaching out to, if you want to see something else in the next one, or you really think something would be helpful for you guys, reach out to me. I'm happy to do it. I enjoy doing these, and hopefully my little coaching business, a consulting business, keeps me going so I can keep doing it for you. But all right, have a great night. I will talk to you later.
Thanks, Logan.
Bye, guys.
Thanks, Logan.